General constipation. Defined as 2 or more of the following for the past 3 months once irritable bowel syndrome with constipation has been ruled out. At least a quarter of the defecations are associated with straining, harder lumpy stools, sense of incomplete evacuation, sense of anorectal obstruction, or the need for manual maneuvers to facilitate defecation, and fewer than 3 bowel movements per week. I always like to think about drugs and other things that can impair or slow GI motor function. First of all, drugs are incretin mimetics like liraglutide, or bowel acid sequestrants like cholestyramine and cholesevelam, aluminum-containing antacids, non-steroidal anti-inflammatory drugs, thiazides, other diuretics due to dehydration, antimuscarinic drugs, opiates, octreotide, calcium channel blockers, particularly verapamil, serotonin 5-HT3 antagonists, and also sympathomimetics. In Parkinson's disease, both the drug, due to degeneration of neurons, and the treatment may delay gastric emptying. In treating constipation, we need to think about lifestyle first. Adequate hydration, adequate exercise, adequate dietary fiber, and discontinuation of those drugs that might be contributory. As we move into the pharmacology for constipation, we can see that there's 7 basic types of laxatives. They're not all created equally. We have bulk formers whose onset is in days, osmotic laxatives whose onset is in hours, irritant or stimulant laxative whose onset is in hours, but faster if you give them rectally, stool softeners that really aren't true laxatives but can help soften the stool to ease passage, opiate antagonists, pretty rapid, lubricants, not truly laxative but can be helpful, and then there's also some specialized agents that we'll see for irritable bowel syndrome with constipation. The first class of laxatives to talk about is the bulk forming laxatives. Things like psyllium, which is metamucil, and methylcellulose, which is fibricon. Their mechanism is that they add bulk to the stool and they help retain water in the gut. They take a couple days to work though. One thing you gotta know, adequate hydration is imperative. Adequate hydration is imperative. Their use is for both chronic constipation and for loose stools, so it can kind of go either way. Adverse effects, flatulence and bloating. Psyllium, metamucil, can cause a lot of allergy in healthcare workers who are continuously inhaling the fine dust from the product. Now let's move on to osmotic laxatives. We have several listed here. Lactulose that we'll talk about on the next slide for hepatic encephalopathy. We already talked about magnesium in the form of magnesium hydroxide, milk of mag, but also magnesium citrate. Can be problematic in the renally impaired because magnesium can accumulate, and when we use them as an antacid, it may cause diarrhea. Polyethylene glycol with electrolytes for GI prepped in a product called Go Lightly, where you have to drink a whole big gallon of this stuff, and you start drinking it before colonoscopy until your stool comes out clear. And then there's also Miralax that does not have electrolytes. It's used for chronic laxative effect. Sodium phosphate, a product not widely used because of problem in renal impairment. And then those sugar alcohols that are not completely absorbed in sugar-free candies. That 50% of the sugar alcohol that's not absorbed can act to produce an osmotic laxation. Can cause diarrhea. I know because I've been there before. Too much information. Lactulose is an osmotic laxative that's used to treat hepatic encephalopathy from severe liver disease like cirrhosis of the liver. In cirrhosis of the liver, ammonia accumulates, and this can cause an encephalopathy, changes in cognitive function. So lactulose is of value for a couple of reasons. Number one, it's going to lower the pH of the gut, and that's going to ion trap ammonia because ammonia becomes ammonium ion in a more acidic pH. We're also producing a laxative effect, so that ammonium that's trapped in the GI tract is now lost with the stools. And also the lower pH can alter the gut flora to help reduce ammonia formation in the first place. This is kind of a busy slide. We're going to talk about 3 different categories of drugs. One of them is a laxative, the stimulant or irritant laxatives. We're also going to talk about stool softeners and lubricants. So starting with the stimulant laxatives, they do not stimulate the CNS. Rather, they irritate the GI tract to stimulate secretion. So this increased secretion increases also peristalsis, onset 6 to 12 hours of sometimes crampy defecation. With chronic use, we get dependence. In other words, if the patient suddenly stops taking their stimulant laxative, they no poo. They can also cause pseudomelanosis coli, as seen in the insert. It's a discoloration of the superficial layers of the gut lumen. Moving on to the softener, docusate, either docusate sodium, which is cholase, or docusate calcium. It's really a detergent that helps emulsify the stool so that the stool's softer. Straining during defecation, particularly in those patients who have cardiac issues, can lead to an increase in vagal outflow, severe bradycardia, maybe even unconsciousness. So this vasovagal bradycardia is something we want to prevent in patients patients with cardiac conditions. We often use Docusate also to help prevent constipation and other conditions. We have a coating agent, a lubricant called mineral oil. It's going to coat the stool with oil to prevent water resorption, at least theoretically. Lots of adverse effects, so including chronic use leading to fat-soluble vitamin deficiency, losses of A, D, E, and K, but also upon aspiration can cause a lipoid pneumonia. Glycerin is another lubricant. It's safer than mineral oil and it's often used as a suppository to lubricate stool in pediatric patients. One of the things that causes overflow diarrhea in pediatric patients is that when it hurts to poo, they just don't poo. They can get a fecal impaction and then the liquid stool will leak out around the impaction. So this is something that we can use to help babies pass stool more comfortably and make them less likely to try to avoid defecation. We sometimes use opiate antagonists to treat severe constipation that's opiate-induced, and also occasionally for post-op ileus. These guys are not absorbed systemically. They're generally ionized at physiologic pH. They don't cross the blood-brain barrier, so they work locally in the GI tract to produce a pretty rapid and profound laxative effect. Trust me, it's not pleasant to be around. Linaclotide, or Linzess, activates the guanylyl cyclase to open that CFTR chloride channel. It may also reduce visceral pain, and it's used in irritable bowel syndrome with constipation, sometimes in chronic idiopathic constipation. The biggest side effect is going to be severe diarrhea. Lubiprostone, Amitiza, is a prostaglandin E1 derivative. It directly activates the CLC2 channel in the apical membrane to increase chloride, sodium, and water excretion. It's used for irritable bowel syndrome with constipation, chronic idiopathic constipation. Biggest contraindication is going to be bowel obstruction because it's going to increase peristalsis, and you also wouldn't want to use this drug in a patient who already has diarrhea. There may be some spillover to some of the receptors in the lung, so it may cause some dyspnea, and its use hasn't been investigated in pregnancy. And finally, in conclusion about the poo, this is a summary of laxatives and agents for irritable bowel syndrome with constipation. Now we'll move on to the final section of GI2.